Frozen shoulder surgery. Our preferred technique to address resistant frozen shoulder or adhesive capsulitis is an arthroscopic technique. This starts with first establishing a portal to allow visualization within the joint. It's important to be very careful to enter the crease between the superior aspect of the humeral head and the rotator cuff to avoid damage to normal tissue. Here we establish a working portal in the rotator interval, and a radiofrequency wand is used to slowly remove the thickened and contracted scar tissue around the coracoid process that allows us access to the subscapularis tendon. It's easy to see that all of this tissue, everywhere we see, has a very red, angry, and inflamed appearance. And the web-like structure of the scar tissue encompasses everything. With continued careful work, we are able to fully visualize the coracoid process and the subcoracoid space. Here we start to see the subscapularis tendon. We continue to work, making sure all our instruments are pointed in a safe direction away from normal tissue. Here we've nearly completed removing all of the scar tissue and inflammatory tissue from the subscapularis tendon. The tendon itself is normal. Now on the deep surface of the tendon, we are moving ahead with resecting the inflammatory and thickened capsule down to the 3 to 4 o'clock position anteriorly. We next turn our attention superiorly, coming up towards the 12 o'clock position where the long head of the biceps is seen to the right of the screen. Again, we very carefully remove all of the scar tissue. We now turn the radiofrequency device deep to the rotator cuff and superficial to the biceps and labrum from the 12 o'clock position, coming around to the 11 and then 10 o'clock position. Here the scar tissue adhering the rotator cuff to the labrum is released. We can see the inflammatory tissue investing everything. When it involves the tendon like the biceps tendon, that's called tenosynovitis. Here we are coagulating some of that inflammatory tissue. Next, we switch and view from the anterior superior portal and instrument from the posterior portal. Here we continue the release of the capsule, also called capsulotomy, from the 10 o'clock position posterior superiorly on the deep surface of the rotator cuff, and we continue it on inferiorly. Now we turn from the 9 o'clock position on down. Here we see that we're across the 6 o'clock position, almost to the 4 o'clock position again in the anterior inferior quadrant. We're now looking again from the posterior portal and using a basket resector, removing the last bit of thickened capsule from the anterior inferior quadrant. Any loose scar tissue and thickened capsular tissue is removed with a shaver. We now also confirm decompression of the quadrilateral space with release of the long head of the triceps origin down at the 6 o'clock position. The shoulder is now taken through a range of motion, confirming full restoration of internal and external rotation. We often find significant involvement of the subacromial space with the inflammatory process, and often even with full release in the joint, there will still be a lot of scar tissue and restriction of motion in this space. Here we can see a significant amount of inflammation involving the superficial surface of the rotator cuff, as well as an incredible amount of inflammatory tissue, here called inflammatory bursitis. The shaver is again used to remove all of this synovium and inflammatory tissue. The inflammatory bursitis has been removed with a shaver, restoring full range of motion. Now we follow up with the radiofrequency device to coagulate the bleeding tissue and ablate any of the inflammatory tissue. It also can be very useful to help us dissect in a safe manner. For instance, in this patient that also had concurrent axillary neuritis and suprascapular neuritis, we will decompress the suprascapular nerve. Here, a modified supremedial portal is established with spinal needle localization, followed by a smooth 5.5 millimeter cannula. We use the radiofrequency device to slowly travel up the conoid ligament until the point of the coracoid is reached and the suprascapular notch. This is an inverted view with lateral towards us and superior at the bottom of the screen. So as we come down onto the transverse scapular ligament, we can see the nerve traveling beneath the ligament and the artery traveling just above it. Once this has clearly been visualized and dissected, we introduce arthroscopic scissors to decompress the suprascapular nerve. A significant advantage of arthroscopic treatment for resistant adhesive capsulitis or frozen shoulder is our ability to be able to treat concurrent pathology that might limit the patient's ability to regain and keep the motion given at the time of arthroscopic release. You can learn more at theshouldercenter.com.